coming?
Yes, definitely. Yeah,
Okay.
we're looking at about 90%.
All right, great. So whenever you guys want to start, Diego, you want to kick us off?
Hey, good evening, everybody. Welcome to January 2021, hindsight 2020, thankfully. And we're introducing our PCP advisory meeting. If everyone could put their name in the chat for attendance so Kevin can keep track of all of us, that'll be great. And Renee, do you want to go ahead with the Medline topic?
We have with us tonight Christopher Earle, who is a representative of Medline, which is an organization, and I'll let Chris get into the gory details about the type of organization. But essentially, what they provide are medical supplies and things like PPE and a whole wide range of services that are useful to practices. And we're excited to talk to you, to have Chris speak with you, because AHP and Medline and ProVista, another company that's part of this whole alliance, we've partnered with them to provide AHP participating practices, so this is PCP and specialists, those folks in private practice, access to a relationship with Medline that will give them the same pricing on medical supplies as Medline gives to URMC. So as you can imagine, with the size of URMC and their purchasing power, that's pretty good pricing. We've been working with them for several months. I got to give full credit to Chad and Kim Povak. They have really shepherded this through, worked with Chris and some of his team members on doing some analyses with some of your practices who've agreed to share information. Diego, your practice was one of those, to help us do a compare of based on your activity, based on your purchasing history of medical supplies with your current vendors, how would you do under a relationship with Medline? And the savings, were in excess of 25%. So this is a significant benefit we feel for private practice. We think that you are, if you're interested in speaking with Medline and working with them, you are working with a vendor who, great customer care, great product lines. You're going to have access to PPE better than you have from your current sources. We all know what it looks like when you can't have access to the PPE you need. And they're really focused on meeting your needs and making the transition easy. We're bringing this to you today. It's not going to be a really long presentation, and we're really hoping that the action item that those of you in private practice that are on this call will do is get back to your office tomorrow or Monday and tell your practice manager that you'd like them to reach out to Medline and start this process and see what kind of savings that Medline can get for your practice. So Chris, why don't you take it away? I'll bring your presentation up. And then we have, and then we'll talk after Chris's presentation about the future of PPE distribution as practices have been doing that with AHP. I want to share a little news about that. So I'll bring your presentation up, and Chris, take it away.
Thanks, Renee. And I just want to say thanks everyone for the time. I know everyone's time is very valuable, so I'm going to keep this relatively short, but I just wanted to use this forum to introduce myself, Medline, the program, and I couldn't be more excited to offer this. I know Kim, Renee, and myself have been working for a number of months and around the holidays, and we finally got this officially, this partnership made it official 2 weeks ago. So just want to give a little bit of background about myself, Medline, and how we really can help your practices, and hopefully, you're able to communicate that to your practice managers, and we can have some real benefits of the program. So my name is Chris Earle. I'm Vice President of Corporate Accounts with Medline. If you don't know about Medline, we are, like Renee said, the main supplier at U of R. But we, Medline, are the nation's largest privately held manufacturer and distributor of supplies. So we pretty much cover every aspect of healthcare, whether it's a physician office, a surgery center, the hospital, home and hospice, or long-term care, as we call it. Even in retail, if you've seen Curad Band-Aids, we manufacture those. So we manufacture everything from Band-Aids up to orthopedic implants. So this opportunity to partner with AHP and really drive some value to the physician office practices was really, really attractive to us because typically we're serving larger groups that have significant buying power, but the smaller practices that we find, I don't mean smaller by doctor size, but the offices that aren't part of a huge health system are trying to figure out how can we stay afloat? How can we be aggressive? How can we work together to get better pricing? So that's where we can come in. So what we did is we put together a program with AHP and said any of the members that would like to join the program with Medline, and this is completely voluntary, but we'd love to have as many people join as possible. We are able to provide the same pricing as U of R. And Renee mentioned Provista. To keep things very simple, we Medline are the manufacturer and distributor of products. The team that really puts together the contracts and the aggressive portfolio of pricing is the thing called Provista, and that's part of the group purchasing organization. To keep it simple, it's a completely free organization to join. What it does, it just gives you buying power as if you were part of a hospital system. And so it's the same system and contract group that University of Rochester uses. So this is a really exciting program, and we're really hoping that we can really drive value to your members. The thing that we really think is most important is access to PPE. I know that over the last couple months, things like nitrile gloves or syringes now, wipes, gowns, anything like that, even face masks have really been a struggle to get. And so Medline, how we're a little bit different is we're a manufacturer, and we really feel that partnering with AHP, you're getting as close to the supply chain as possible. The other companies that are out there, we're not knocking them, but a lot of them are what we call companies that private label product. They may have a logo on that box that says the company name, but it's actually being made by someone like Medline, who actually owns the factories where we make gloves and gowns and drapes and those type of things. So by partnering with Medline, AHP is really able to give their membership access to as close as the supply chain as they can be. So we have programs around gloves right now. We have programs around face masks, syringes. So we're really excited to get to talk to the offices and see how we can help. By no means is this a silver bullet where we can solve every single problem, but we really think that with our spot buy programs and the programs we have around PPE, we're really able to help fill a void right now that a lot of the offices are really hurting. So a little bit about the Medline program. So we have dedicated field reps in your area. I know everything is virtual right now, but we have reps that are able to come on site or do virtual meetings with your offices to kind of talk about, how can we help? What's going on? Where are you struggling? And really just learn more about your practice. We offer next day delivery. So if you place an order before 3 p.m., it's there the next day. We offer obviously everything in low unit of measure. So a lot of times, you're not ordering pallets like the hospital, you're ordering boxes and eaches. We have those items ready to go and are ready to be stocked for you. Again, another touching base on the contract piece, we are accessing the same contracts as U of R. So this is extremely aggressive pricing for your group. And we have a really intuitive website that we can help place orders on, build formularies, and really kind of bring some structure and order to the buying process. We also have a nice program that can help with barcode scanning and really kind of do a vendor management or purchasing management program. So we can look at that if you're interested, but we just have so much to offer. And I really just want to use this time today to talk about Medline, who we are, and just let you know that we're really excited to partner with your practices and your offices. And by all means, this is completely voluntary, but we really would appreciate if you just go through the process of doing a cost study and see what the savings would be. And I think, Renee, if you go to the last slide here, this is just a quick little snapshot of what we Medline can offer. The pilot studies that we did, the savings were much, much higher than we were anticipating. Typically in this space, we see anywhere from like 10 to 15% savings, but the 3 cost studies that we really did for some of the larger practices were over 25%. We're talking tens of thousands of dollars that we can help drive savings for. And a lot of the items are the same items you're purchasing today. We're just accessing a contract that's part of the hospital. So you're buying the same 3M item, whether it's a 3M Steri-Strip or if it's a Ethicon suture, it's gonna be the same type of suture or same type of 3M item that you're using today. We're just accessing some really, really aggressive contracts from the hospital. So I'd be happy to take any quick questions you might have, but I think the best thing to do would be take down my information here. I'm sure Renee can pass this along, and we'd love to have a one-off conversation with NAD practices here, but just want to say thank you for the time. And we're really excited for this partnership. It's been a long time coming. I think we worked on this since the summertime. So we're just ecstatic to have the opportunity to really service your market. So thank you.
Chris, any questions for Chris? Any questions for me? Is there anything in the chat? No? Okay. So I'm sorry, was that a question?
No, Renee, that was just me. I just want to say thank you for the opportunity. And if you have anything to add, I know I threw a lot at everyone, but I just wanted to be respectful of your time. So if there's anything else, Renee, that you would like to add, I'm happy to kind of comment on it. But I think that was a quick overview of the program and a quick overview of Medline.
No, we appreciate that. I mean, I think the most important, things for our, audience here tonight to remember is 25% savings potential for you to switch. And, I think that with the support from Medline and the team that they've got, that every effort will be made to make, if your practice chooses to make a switch, to make it easy, to not make it a pain for anyone or take up too many of your staff or your hours to get done. I know that's sometimes the barrier to making a change like this. Is just the thought of mustering the resources to get it done. But I'm confident that, Chris's team will be, really at your practice's service to get this done as efficiently as possible. And it's because we have this rule, and I'll transition into my other topic I wanted to cover with the group. Now that we have this Medline arrangement, we want you to be able to take advantage of it, get better pricing on your medical supplies, including PPE, have better availability of what you need, and have better pricing. We feel that this is the appropriate time as well to sunset our twice a month PPE distributions that AHP has been doing. We started this back in March when it became clear that there was a crisis and that folks were not going to be able to get the PPE they needed in order to continue to care for patients safely. So, we were happy to do it, and Chad has done an amazing job scrounging. I mean, that was certainly what it was in those early days, right? I mean, we were driving around to Home Depot and sweet talking assistant managers to putting aside a case of N95s. I mean, it was nuts. And then eventually that settled down and we were able to tap into the U of R supply chain, and we've been happy to provide you, some limited PPE. But now with the advent of this relationship, the fact that we understand that even through your current sources of PPE, the availability is no longer an issue. We understand price may still be an issue, but availability isn't. That this is the right time for us to sunset our efforts for PPE distribution. So we anticipate we think we have about a 2-month supply remaining. We're going to give all that away, do the same processes we have been doing every other week, sending out the survey, doing the distribution. And then we will, once we're out of PPE, that will be the end of that program. We've been happy to do it. We're sad in a way to see it go. We have a lot of fun putting it together, but it certainly has been a challenge for us to sustain it, just by the way we're organized and the way we're resourced as an organization. So any questions for me on that? Oh, I see a chat from Dr. Nasser has a question. Is this the same Medline that has online medical information content? I believe it is.
So I can talk a little bit to that. I believe there is a Medline out there that has some maybe peer studies or something like that. I'm not too familiar, but we have a program that is like for continuing education. I'm not sure if that's what you're referencing, but I believe we're not the same company that has the
one day, like I was crying.
Yes, I was referring to the CME content online. Okay.
No, different company completely, but we do have some continuing education information that if your offices can take advantage of at no cost, but different company than the CME.
Okay.
This is Chad. I will also point out, even though we'll be sunsetting the PPE distribution program through AHP, and as Renee and Chris have pointed out, really you should have today's access at probably at or better than probably even pre-pandemic pricing compared to what you've been used to individually with your GPO relationships. If we ever get to a time that PPE again becomes in short supply, or we again find critical issues, we still maintain our link to the U of R purchasing power and sourcing distribution that they have, so that, you know, if we needed to re-engage supply chain for a certain supply line that was in limited distribution, even to Medline, and U of R was able to find some sourcing outside of normal distribution, we could still tap into that and go back to our prior distribution plan if need be. But day to day, this hopefully will be a better and more efficient program for all of you going forward.
Awesome. Well, thank you, everybody.
Thank you.
Thanks, Chris.
Take care.
Yeah,
Have a
thank
good
you,
night.
Chad and Renee. The PP has been phenomenal. I think it really has helped a lot of the smaller practices. I think it's been a wonderful program. So now having an opportunity like this for Medline to offer these practices, ability to purchase and order on their own, I think is great. So I think it's fantastic. Okay, so we're moving on to 2021 quality measures. Dr. Teeters, all you.
All right. I should mention, Renee's being a bit kind as far as not mentioning the full benefits of this group purchasing organization, but it extends to telecommunications discounts, computer purchasing. So it actually is a pretty robust purchasing program that, again, any discount that the U of R gets essentially would be made available to all of your practices. So it's more than just supply lines, which is actually very nice. So Renee's not doing herself justice for everything that's included in this bag of goodies that really is no cost. And for all intents and purposes, we looked at different supply lines that practices were using. They looked at the most common supply lines from other distributors. And if it's not an exact replica that they're distributing, they have a, Pepsi and Coke version that's essentially the same thing. It just may be a different color or in a different box, but for all intents and purposes, it's the exact same equipment that you're used to using. So should be hopefully a great opportunity for everybody at cheaper than what you were even experiencing pre-pandemic. So lots of opportunity there. All right. So without further ado, despite the pandemic, we still have a normal course of business. And it's about this time every year that we like to share our progress with the payers and our quality metrics for the upcoming year, knowing that by the time we get our locked population, which usually is by the end of March, beginning of April, so Arcadia will be live with the population that we are on the hook for this year, and with all of the metrics that we're getting ready to show you for your viewing pleasure and pre-visit planning use within the next couple of months as everything starts to flip over. I am extremely pleased to say that once again, the metrics that you're going to see tonight are completely unchanged from what you've seen last year. And in fact, the list is actually a little bit shorter than what you've been dealing with even this past year. So we continue to work with the payers to try to manage that list so that you're not dancing to 23 different metrics spread across 2 or 3 payers. We are also trying to keep point totals about the same so that distribution is kind of what you're used to. So there's going to be nothing on here that you haven't seen before. I will talk at the conclusion of this. While we have the metrics that we're going to call kind of our work metrics, if you will, every year we take for a dance a certain pool of metrics that are either of interest to the payers or potential metrics that could be beneficial for us for the future. Now, why do we do that? So, for instance, this year, diabetic nephropathy, a metric that has been a little bit of a pain, let's face it. It's sometimes difficult. We get to the end of the year, thresholds change, and we kind of have to do a chase. Diabetic nephropathy was actually sunsetted by HEDIS, so it is no longer an active quality metric. So that one will not be on our list this year. But we have to maintain a certain number of metrics with the payers to maintain our point distribution. So if there were 2 more metrics to sunset at the end of 2021, we would likely have to have a metric or 2 in the bag that we could be ready to go with in 2022. So that's the reason we keep this kind of on-deck pool of metrics that oftentimes we're not bugging you with, because we're kind of working out the kinks, trying to figure out what the reporting and validation issues are. And then if we need a metric to dip into, we've got a tried and true and validated metric that we're ready to go with the next year. So we'll talk a little bit about that pool, But again, that's just going to be kind of AHP eyes only. Happy to discuss those throughout the year. And if it looks like there's interest or clinical need that we should devote some attention to it, we'll raise that separately. But the metrics that you will be judged on or dancing to for gain share purposes are going to be those metrics that we share with you tonight. So with all that said, and feel free to interrupt me at any time for whatever reason. My computer keeps telling me that I have an unstable internet connection, so all of you are not moving. I just see still faces. So either you all have the greatest mime work ever going, or my daughter is watching hordes of videos right now and I can't have an adequate Zoom work. So this list should look very consistent to what you have seen in the past. So you will see it on the left side, the short name of the metric. And column B is the definition or kind of inclusion criteria for the metric. And then you will see the breakdown as to what applies to adult patients and what applies to pediatrics. Then you'll see which line of business these metrics correspond to. And then on the far side, you can see the benchmarks and how that benchmark has changed for the 90th percentile compared to 2020. So going down the list, the first few are what we call core metrics. These really do not change year to year. These are kind of the quintessential primary care metrics that are a part of really all value-based contracting. So breast cancer screening, colorectal cancer screening, diabetic eye or diabetic retinopathy screening, A1C less than 8, hypertension, blood pressure control. Those are the core metrics that really appear year after year. Fall risk is one that we have worked on in the past. Excellus last year had kind of wanted to sunset that one, but then for whatever reason, they realized that the performance was not as good when they did that, so they brought it back. And fortunately, this is a metric that we have done very well on, so we were more than happy to accept that back onto the grid for this year. Really thankful to Elizabeth and even Kim Povik when she was in Elizabeth's position before. They had worked on fall risk management previously, so that once you do the screening, automatically the patient kind of falls into the numerator. So this is one that theoretically, if you do it, you automatically meet the criteria at the same time. So it's really a win-win on that metric. I'm going to skip depression for the moment and come back to it. And then we'll go right into the pediatric measures. So these two really have not changed. So well care 15 months, that metric remains. Lead screening in children also remains. Adolescent immunization, last year we went to combo 2, and we are staying with that this year. We performed at the 90th percentile for that metric in the last year and actually did quite well. Childhood immunization combo 3 also has been a tried and true measure for us that we have historically done very well. I know there's no pediatricians on the call, but there are family physicians on the call. We've got a couple med peds. So many of you may say, what happened to adolescent well care and well child 3 to 6? What happened to some of the other well care pediatric measures? So all of the well care metrics, 3 to 6, adolescent well care, those have now been sunsetted, and HEDIS is combining it into one well care pediatric measure from age 3 to I think 19 or 20 or 22, something like that. That measure does not currently exist, so it is not up for grabs this year. So that sunsetted some of those well care metrics that we have traditionally put on the pediatric grid in the past. Depression screen and follow-up is what I'll call bonus metric. So this is a collaborative metric that we are working with Excellus on. This year, our goal is to get everyone screening PHQ-2, PHQ-9 at preventive care, well care visits, yearly physicals, and to not only improve our screening rates, but make sure that we are using that PHQ-2, PHQ-9 screener so that we're all working with a homogeneous data set. Going forward, we are, Excellus, without getting into a whole lot of details, is wanting to develop one initiative that becomes an enduring initiative that runs from 2022 to 2024. So depression screening and behavioral health is going to be our enduring program. So we'll talk more about this as we approach next year. But depression screening, next year we actually want to take and part of the performance will be performing to this actual metric. We will also want to have the ability to document and codify the PHQ-2, PHQ-9 scores so that we can extract that within Arcadia. Ultimately, we're going to want to track follow-up, track remission rates for those who screen positive and time to remission. And then once we do that, we believe by the time we get to 2024, we will have a robust enough depression screening and follow-up program that we'll be able to look at utilization and cost and total cost of care for that patient group. And for those who screen positive and we intervene with some type of depression intervention, that we actually will be able to drive down their total cost of care and utilization. So that will become an IPC over the course of the next couple of years. So this one's going to be kind of a staple that we're going to see on the grid for years to come, is what I'm getting at. When you look at your point distribution, each one of these metrics is going to be worth 10 points. So it's going to be very easy. So when you look at your points possible, if you are just an internal medicine provider, there are 7 metrics on this screen that you can dance to: breast cancer, colorectal, diabetic eye, diabetic A1C, hypertension, fall risk management, and then depression screening. So each one of those will be worth 10 points. For pediatrics, there are 5. Depression screening obviously only applies to 12 and older, and then the WellCare 15, lead screening, adolescent immunization, childhood immunization. So when we do our percent of possible points achieved, each one of those will be worth 10 points. So your points will be based upon how many points you earn out of that total that are applicable to your sphere of practice. That's a lot of words. I'm going to pause for a second before I go into the next section and see if anybody has questions about this, what I would call front page Arcadia metric list.
Chad, one of the problems we've had with our EMR was capturing the fall risk assessment. We've been doing that, for the past year, and we've been kind of looking through that. And I hear that it's being worked on even as we speak a little bit, but what if that piece is not completely able to transcend the EMR? Is there going to be a chart review? Is there going to be something to back that up for the private practices that don't use Epic?
So actually, no, I'm going to defer to Elizabeth a little bit because a lot of the data validation work she did previously. So I believe MedInt has a pretty robust, do you use MedInt, Diego? I can't remember.
No, we have ChartMaker.
ChartMaker, that's right. So we do have data validation programs that were built out previously. Elizabeth, I know you're on. I don't know if you have any.
Yeah, so actually, I know Willie is currently working with Susan Murray pretty closely on the fall risk because there have been a lot of issues. I mean, I'm very hopeful that we're going to have all of those ironed out before the end of this year. But if not, that's certainly something we could take into consideration. Especially, it's not like your practice has not been engaged in trying really hard to fix these data issues. So I don't have an answer like, oh yes, we'll definitely do a chart review. But you guys have been partnering with us on this for, I don't know, a year at this point. So I don't think that we could in good conscience say, too bad, you don't get the points.
How many different EMRs are there in our community? It's got to be more than just Medit, Epic, and ChartMaker, right? So there's got to be at least 5 or 6. So the concern is not only for mine, but for others, right? 10, okay.
Yeah, so there's 10 spread across the entire network. And, to Elizabeth's point, this is not meant to be penal in any of these. So if we know there are clear data validation issues, obviously we have grounds to be able to kind of make determinations in those cases where we know there's clear data problems that you can't possibly be expected to overcome. But as a network, historically, we've done very well with this metric, so we felt comfortable taking it back on.
Right. I feel we have the data. It's a question of, is the data being able to be read, right? Which is what we have problems with many things with Arcadia at different periods of time. So it's just another one of those little roadblocks that we find. Right.
Yes. I mean, if that becomes a prohibition issue, then, obviously we're not going to hold people to account for things that are Arcadia's issues, not their own. Any other questions or concerns that people have? Anybody want more metrics that they wanted to add on just for fun because they miss doing more? Didn't figure. Okay. So now on to this brief discussion of the other metrics that are not on this grid or in that what I'm calling on deck or AHP Eyes only. So you may remember that we had talked last year about the fact that New York State, for any value-based contract and for all of their Medicaid contracts, is requiring that you take at least one metric across 7 different domains. So for instance, HIV AIDS is one domain, preventive health, primary care is one domain, maternal child health is one domain, maternity care is one domain. So you have to pick at least one metric in each one of those. So there are several metrics that we are trialing this year. Almost all of them we get to take as report only. So that's one of the reasons we're not making you do a lot of work, because it's our contract performance is not hinging upon exactly how well we do, but rather it's us taking a test drive and just seeing how the reporting works. So things that will be included in that will be prenatal, postnatal care for women, cervical cancer screening for women. I know when I said prenatal, postnatal care, I probably didn't need to say for women, same for cervical cancer, but that's the metrics definition, not mine. So that opens up a new door that is going to be, and we've gotten Excellus to agree to work with us. Can we actually create an attribution methodology for OBGYN? So that these are metrics that are really best worked on by that group. Obviously, there are some of our family medicine folks who still do maternity care, so it would apply to them as well. This is partly in response to, there's been a host of primary care physicians who have said over the years, why is this always on us? Why aren't the specialists engaged? Why isn't OBGYN engaged in these metric lists? Shouldn't that be where we're going in population health? So that's our foray into this new engagement of other specialties and OBGYN, because there are discrete encounters and episodes of care, such as maternity care, would be one of the easiest ones to do that in. So we're going to be taking those for a test drive this year. HIV AIDS, there is only one metric that is up for discussion, which is viral load in those who are HIV positive. And it had not only that you check a viral load, but it has to be above a certain threshold. I think it's 200. I can't remember off the top of my head. So that one, the metric has not existed inside of Arcadia at this point. So we're going to have to test that out, see what the thresholds look like. We really have no estimate of what our performance is at this moment. The other ones, just briefly, so opioid or medical assisted therapy for patients, or initiation for patients with opioid dependence. So that's one of the domains, is substance use disorder that the state's requiring. So we're taking that one for a test drive. Another is mental health follow-up after ED visit within 7 days. So somebody presents to the ED with an acute mental health crisis. They have to have follow-up by a mental health professional within 7 days of discharge from the ED. Those last two that I mentioned, the substance use, the medical assisted therapy and the mental health follow-up, have been metrics that we have notoriously had a lot of problem with. They're difficult definitions, they're difficult populations to follow. And so those are going to be some stretch goals to see if we can work on any data efforts around those. So you can see there's a bevy of kind of difficult metrics. Some of the ones that are a little bit more wheelhouse for primary care, statin adherence for patients with cardiovascular disease. Now, this is one that we've actually done very well. Taking one medication adherence metric was extraordinarily important to Excellus, and we got other concessions for taking that on. History tells us that we have notoriously done above the 90th percentile with that metric, but we'll be taking it for a test drive to see. The next is statin initiation for those diagnosed with acute cardiovascular disease. So MI, stroke, getting a statin started. So again, that's one that hasn't existed on the grid that we're going to be taking for a test drive, but we would hope that we've done very well in that one. And again, that has some tendency to the subspecialty realm to some degree, because that'll engage cardiology and neurology. So that's the list of what I'm calling the AHP Eyes Only grid. Obviously, happy to talk about those, happy to talk about what our performance looks like, but we didn't want you guys having to stare at things that really don't have direct relation to our contract performance, because those are report only this year. So we're kind of getting those points just for taking them out for a trial. The one other one that I should mention is flu vaccination for the elderly. That has been a metric that has actually been on our grids either in the background or directly for a couple of years now. However, we notoriously perform at or above the 90th percentile, but Excellus has had a lot of issues with having all the data flow into Arcadia. Specifically, they receive claims codes saying a flu vaccine was administered, but they just get the NDC code of the drug. So last year, for example, we were about 3,000 patients short in Arcadia from meeting the 90th percentile. But when you look at the number of pharmacy claims for flu vaccine, we had 6,000 patients that were not included in Arcadia as having got the vaccination. Up until last year, Excellus was making the argument there was no way to know for sure that the patient actually got the vaccine. So the suggestion was that the pharmacy dispensed a vaccine to them and they just took it home in their hand and put it on their shelf and left it there all year. So clearly that's not the case. So we were able to compel them that if the vaccine was distributed, it actually went into their arm, not just into the shopping bag to go home. So if they can make that work this year to where it directly feeds the metric, then obviously that will be something that we would put forward on the grid going forward, because obviously I think we all believe that flu vaccination is an important thing. So all of these things are part of the litany of discussion that goes on. But I think with the grid that we showed you tonight, based on our historical performance, we should be positioned to do very well again in our contractual performance this year. And I see there's a ton of questions. Sorry, I was just talking.
Dr. Bowler about Cologuard.
Cologuard is a four-letter word that we shall never speak of again. So yes, Cologuard is an alternative. A couple things I will say briefly about that. So it is an alternative. The cost effectiveness has improved from even when we released our colorectal screening guideline. It still is not, and truthfully will almost never be, on par with FIT screening. In the last couple of weeks, there's been a litany of data around FIT screening and its advantages and potential on parness with, and I realize on parness is not a word that I just made up, but you know what I mean, with colonoscopy. So yeah, I think this will be an ongoing discussion. I think our goal has been to say we would not recommend use of Cologuard as routine, but if it is the only colorectal screening that a patient will submit to, certainly colorectal screening is better than not colorectal screening. But in general, appropriate use of FIT testing on a yearly basis is just as good, if not better than Cologuard, depending on what studies you read.
Elizabeth, do you want to answer Dr. Markakis' question about what counts as an intervention for fall follow-up besides a PT referral?
Sure. So I'm actually going to pull up I'm not going to share it, but I'm going to pull up a document because it has been a little while since I've paid attention to fall risk as well. When we worked on this in the past, one of the things that we put together was a recommended plan of care that kind of covered the check boxes, because the things that count, if you will, are, sorry, I'm looking through this now. A follow-up encounter with their PCP with evidence of fall risk intervention or a physical therapy encounter. And so we do have that referral to PT, but we know that that can sometimes be challenging to capture. From a clinical perspective, we built out that plan of care in MedEnt and are happy to partner with some of the other EMRs if folks are interested, but including things like education about falls and fall risk, environmental risk reduction. The calcium and vitamin D supplements is something that I know folks have talked about quite a bit. In addition to referral to PT, referral to specialists, to care management, medication review and education, and potential DMEs.
And I believe documentation of using a cane or walker counts as well, correct?
I would need to double check on that. Willie, I don't know if you know that off the top of your head, but I just want to.
I think that falls in the DME category.
And one quick follow-up on that. Is it just specifically fall risk, or is it also gait abnormality or balance difficulty? Are there other codes that put patients into the denominator other than fall? I guess that's, I don't recall. For some reason, I thought it had to do with at risk for falling as well, but it may be a separate metric that I'm thinking about.
It's patient is 65 years or older and has a diagnosis of a fall or problem with balance during the measurement period.
It does say, okay. All right, thank you.
Sure thing.
So the issue is just a documentation for that encounter where fall is documented, that education has been given, because many patients will turn down PT, unfortunately.
Yeah, and it's not always appropriate, frankly. Somebody could fall into the denominator, no pun intended, if they're over 65 and slipped on some ice. They might not need that full-on education, except like, hey, be more careful when you're walking outside in wintertime. So that was one of the reasons that we built out that plan of care, was to assist with the documentation when, in fact, there could be different appropriate clinical interventions. And we're happy to share that out. I know that we have a lot of resources on the AHP website around quality measures, and I imagine that we'll be adding fall risk to that list this year as well.
Is that plan of care in Epic, Elizabeth?
No, although we shared it with the primary care network way back when. Again, we'd worked on this a couple of years ago, so we need to, I think, as we're picking it up for 2021, re-engage and see what's being done with that. And I know that in Epic, the post-visit summary that prints out includes some fall risk education if indicated. And so I believe that that checks the box in that case from a documentation perspective.
A good time to mention, or to remind folks, we showed this to you, I believe, last year, the information that Elizabeth is sharing about the specifics about a measure. Those resources are on AHPnetwork.com, and it's the good work of Willie Udigant and Kevin Kelly who put this together. So I just want to share that with you really quickly, where you could find that. That is on our website under partner resources, and then there's an image that shows 2020 measures, and these are the 2020 measures. And when you click on hypertension blood pressure control, you're brought to a really great description of the measure, the target, the percentile threshold, changes from the prior year, and all the things that put someone in the denominator and all the possible things that'll get them into the numerator. So I just want to make that plug for all the detail that Elizabeth was sharing on fall risk. We will have that updated for 2021, but for 2020 measures, that information's out there already.
Thank you.
Good. Any other questions folks have about metrics? So one quick plug, and actually kudos, and I know this is not on the agenda, but all of you probably know, and all of you, whether you directly remember or not, have been involved in the readmissions program that we launched as a pilot at Highland in 2019, and is now pretty much medicine service wide at Highland and Strong. So thanks to the hard work from the teams at both hospitals and you and your care management teams, we did get some early look at the data thanks to Christy and Matt Reeder from AHP, who've been working on the analytics for it. So our goal with this readmissions effort was to reduce readmissions by 15% year over year. So we started in November of 2020. The readmission rate in November of 2019, so our baseline year, was 13.9%, and the readmission rate in December of 2019 was 13.4%. Fast forward to the 5 contacts program rolling out this year and all of your efforts. The readmission rate in November was 10.4, and the readmission rate in December was 9.5. So we are currently trending at about a 25% reduction in readmission rates compared to last year. That's with about 1,600 patients being discharged into the program thus far in those first 2 months. So from a statistical significance, that reaches significance. If you question whether that was just dumb luck, or patients who are discharged to out-of-network practices, so not attributed to one of our AHP primary care physicians, their readmission rate went up in those 2 months in 2020 compared to 2019. So the work that you guys are doing, the work that's being done in the hospitals, does seem to be having a direct effect. So thank you and kudos, because there's literally millions of dollars riding on that going as planned. So that's another effort that you guys have performed extraordinarily well on thus far. So way to go.
Everyone gets a gold star. That's good.
That's right.
Good. So I
I'd
think
hand out
we're,
cookies if
so I think we're at the open forum of our discussion. So we have the Honorable Dr. Michael Mendoza on with us. So I was wondering, Dr. Mendoza, if you could speak a little bit to, a lot of us private physicians have ordered vaccine through the state in order to be able to open our own clinics in our offices for our patients. And have protocols to kind of be able to deliver, large amount of vaccine if we were to receive it. And, we've applied week after week and not really received any. Do you have any understanding of what the plan for private physicians to incorporate into this plan would be for the state?
So I don't think the private physicians or even small venues are due to get vaccine anytime soon. As I say that, I always have to say I never know what the governor's going to do. But, the writing on the wall is that, we're aiming for large volume facilities. So, on the order of thousands a day. And I'm not sure that the average practice has the capacity or space to do such a thing. So we're looking at, obviously the convention center, the Dome Arena. We're looking at large sites on the far west or far east side. At the moment, the eligibility criteria are divided up into two categories. Number one is people based on age, 65 and older. Those individuals are being told to go to their hospital system, local pharmacies, or the Dome Arena. And then those who are eligible based on occupation are being instructed to go to the Dome Arena, which doesn't have any stipulations, or to any of the sites that are set up by the health department, of which there are three: the convention center, the fleet center over by the airport, and downstairs here at the health department. Obviously, the big problem is that we are getting currently about 1,500 doses in the count in the health department. Across the region, I think Dr. Bennett said that we got, I think, 10,000 or 8,000 total doses, which is a drop in the bucket. So the hope, of course, is that we will get more vaccine in the coming weeks. Our projection for next week is that it will go up only about 15%, which is not very substantial. But I think as the supply opens up, we will need to go to smaller sites. And I think primary care practices and other healthcare settings would be very appropriate for that. But I just don't think that that's likely. Probably not in the next month. I'd be very surprised if individual practices got it in the next month. When the individual practices do get them, I would guess that they will prioritize practices that are serving the inner city, rural poor, the typically marginalized populations in our county. So I think that's the best guess I can offer to you today. And of course, everything can change depending on how the governor feels tomorrow.
Thank you.
Yep.
I have a question. Any comment about when it opens up to those 65 and under, how they're going to sort of prove that they have a chronic medical condition? Is there any talk about how that's going to play out?
Well, the thinking, of course, is that if the eligibility is going to be based on some kind of a clinical assessment, it's going to be given through a clinical setting. So doctor's office, hospital, potentially pharmacies if they feel that they're equipped to make that assessment. But it'll have to be a clinician who has access to a medical record of some kind. And again, to be blunt, I don't think that's going to happen anytime soon. With the opening up to 65 and older, that's, I think, 7 million people in New York. So we're not going to see that anytime soon. But whenever there's a clinical assessment involved, it'll be a clinical type of setting that will be administering that vaccine for that individual.
I can't speak for all the private groups here, Dr. Mendoza, but I would say that a lot of us have protocols in order to be able to deliver a large amount of vaccine. So we actually have the physical plant to, at my office, for example, we applied for 1,500 vaccines. with the intent of getting our 75 and older population across 5 practices. And we can probably do that over the course of a weekend with our staff, the way we've got it set up. So it's always a shock to me that things like Wegmans and CVS, where you think they're smaller venues, can get this kind of vaccine, and us, the medical providers who our patients trust us and know us and are willing to come there and have easy entrance in and out, from a parking standpoint and all that. It's hard,
Yeah, no, I hear you. And I'm not saying it's not going to happen. I just don't think it's going to happen anytime soon.
Are the patients over 65 being notified that AHP has them on a list and will be contacting them?
I believe I saw patients this morning, and there was a MyChart blast email, I think, that went out from Dr. Apostolakis. Is that a communication that's gone out to all patients 65 and older, Steve?
Well, certainly for URMC, I can't speak to the AHP private community, but it certainly has been widely communicated to URMC primary care patients.
And it has been communicated to private as well. So Renee has shared that with us, and that has been communicated through them as well, through our website and information we get from Renee and Chad.
Okay, we're still getting questions from our over 65 patients in University Health Service.
As are we, Ralph. I think, like anything, we think that a certain percentage of our patients are on MyChart and reliably looking at it, and going to the website, it's pretty clear that they don't always do what we think. So we're experiencing the same thing. Lots and lots of calls.
There's a lot of the population that just doesn't use the internet, right? They just don't use email, is not on their radar. And so those people call, right? And that's where we get those calls as well.
And unless you tell me otherwise, I've been telling the public, do not call your doctor and do not call your doctor's office, because it's just not going to go anywhere at this point, is my sense. But if you feel differently, let me know. But that's been our general message. No,
that has been your message. Remember, these people trust us, know us, they know all their doctors, and they're going to call there. When they have a question, that's where it happens. So, and it's part of what we do, right? So it's just one more thing we have to do.
So the new message is call Diego tomorrow morning. Just kidding.
Did I tell you I'm moving to Bahamas? Did I say that out loud, or? Any other topics that people would like to bring up? Awfully quiet. Very good. So 6:55 looks like, as Chad likes to say, we gave you 5 minutes back of your life.
Fantastic. Have a good night, everyone. We'll get those slides out to you later.
Thank you very much, everybody. Have a good night.
Thank you.
Have a good one.
Bye.
Thank you.
Thanks for coming, Dr. Mendoza.
Thank you, Dr. Mendoza.
Thank you.